Excellent. All right. So I shall press record if that's okay. Record to the cloud. Okay. Welcome everyone to our Sydney Neonatal Lectures.
Recording in progress.
I have great pleasure in introducing Professor Tomohiko Nakamura, who is Emeritus Professor from Nagano Children's Hospital. Professor Nakamura is a respiratory expert, and he wrote the chapter of the recently published Manual for Newborn Care of the Very Small Infant from Japan. He was also integral to the care of, I believe, the smallest male infant at 258 grams, is that right, to survive to hospital discharge. And the baby would now be about 7 years old, is that right? I think so. So look, we will get cracking, get moving. Professor Nakamura will present his presentation, and then we'll leave a few minutes at the end for questions and answers. But if you have any burning questions, please feel free to write them on the chat pane for Professor Nakamura to answer at the end. He's given us permission to record this talk, but of course, as usual, we'll see whether there's anything dodgy in the final result before we post it up. So, Professor Nakamura, thank you so much. The floor is yours.
Thank you very much, Professor Julie. Good afternoon, everyone. My name is Tomohiko Nakamura. It's my great pleasure to talk to you. So Nagano is located almost the center of Japan, 2.5 hours from Tokyo by train. So this is an overview of our town, and this red roof building is our hospital. Very famous ski resort, Hakuba, where many Australian people visit in winter. They are very close to our hospital, 1 hour, just 1 hour. And also this is a very famous wasabi farm. It's located very close to our hospital, so we can eat fresh wasabi every time. And also in downtown, we have old castle. So our hospital is only 1/3 level of perinatal center in Nagano. So we covered every sick baby in 10,000 newborn a year. So we have a special ambulance car for transport newborns, sick newborns. So today, this is a agenda of today. So we talk about the 2 topics. First, respiratory strategy for extremely low birth weight infant in our hospital. So Julie introduced this baby. So this baby was born 205.8 grams 6 years ago. So now he graduated the kindergarten. So this is a photograph of he growing very well. So recently we published this article, the short and long time outcome of 22 and 23 Gestalt week infants in our hospital. This is outcome. So survival rate of 22 gestational age is 80%. In 23 gestation week is 90%. So this is a percentage of the neurodevelopmental impairment at 3 years. So in 22 gestational age and 40, 20 in 23, the 20. It is our short and long time outcome recently. So this is our respiratory strategy. So today I will talk until 2020. So we used high frequency high frequency oscillation ventilation. After first use of the synchronizer, we usually 3 to 1 week. So we changed to HFO and ventilate the almost 1 month, and we changed to the NAVA to extubation. At that time, our extubation time is almost 32 gestational week. This is the initial setting of the high frequency HFO. Frequency, we fixed 12 hertz, and the amplitude may be the changed depend on patient PaCO2. This is the target SpO2 and target PaCO2. Maybe it sounds same to you. So after 2020, now we are trying to change little bit strategy of the ventilation. So now we use NAVA as early as possible. And after extubation, we use NIV-NAVA for non-invasive ventilation. We frequently use respiratory stimulation, such as the dopamine, doxapram, and the caffeine during on ventilation to stimulate the spontaneous breathing. And also we routinely used fentanyl for sedation and inhaled steroid in acute phase. So later I will talk about this fentanyl and the inhaled steroid. So NAVA, neurally adjusted ventilatory assist, synchronized on infant's diaphragm electronic activity. EDI, electric activity of the diaphragm, is a very unique signal that shows the breathing volume, spontaneous breathing volume and quality. I think this signal sign should be new respiratory vital sign that give us a lot of the new information. So this window shows we changed from the synchronizer IMV to NAVA. So this is peak inspiratory pressure decreased after the change of NAVA, and also this is a spontaneous breathing effort decreased, same. So this is a typical change from synchronizer IMV to NAVA. So This is a recent our strategy of respiratory strategy. My mission, our mission is trust baby. Trust baby's spontaneous breathing. So we use NAVA as early as possible, and we use caffeine to stimulate spontaneous breathing or something. Next, I will talk to you about the fentanyl. So we have believed fentanyl reduce pain and stress of infant. We believe the small baby has pain and stress in their early life, and also the pain and stress induced severe complications such as IVH, neck, sepsis. So we have used fentanyl to reduce pain and stress. However, there is no evidence fentanyl reduce pain and stress and prevent the severe complication. Now, I'm very worried about the risk of fentanyl on neuron and neurodevelopment of very early premature infant. So I think next is this. Family reduce pain and stress. Next, we would like to try couplet care in delivery room and in NICU in early phase. This is the mission, new mission of us. Trust family, reduce pain and stress during their early life. So I would like to move to next agenda, inhaled steroid. This figure showed very important, a lot of the important information. X-axis is the rate of BPD in control group. Y-axis is the effect of death or CP. So red circle group study has low risk of infants with BPD. Has if they use steroid, much more risk factor is higher. However, if we use in very high risk infants with BPD, the effect of corticoid has a much more benefit, This figure shows very important information to us. So our question is, what is the highest risk of BPD? Well, you agree, early gestational age, and also intrauterine inflammation, chorioamnionitis. So we have done randomized control study of early inhaled steroid use in Japan. Our primary outcome is death or severe BPD who need home oxygen. Secondary outcome were neurodevelopmental impairment at 1.6, and 3 years old. This is a outcome, primary outcome. Infants in 24 to 26 gestation age, we had significant effect of inhaled steroid, and also or with chorioamnionitis. Inhaled steroid has a benefit to prevent severe BPD. This is the second outcome of the death or neurodevelopment, neuro impairment, neurodevelopmental impairment. There are no effect on death or neurodevelopmental impairment at 1.6 and 3 years old. So this is a conclusion, our conclusion. Inhaled steroid decreases the severe BPD with high risk infants. That means the early gestational age preterm infants and also the uterine inflammation. And also there's no adverse effect. When we have done this RCT at that time, same time, your European group published New England Journal, the same randomized controlled study. Their result showed inhaled steroid had adverse effect of the death. However, we didn't have showed the adverse effect. The reason why we didn't, they showed the adverse effect of the death. I don't know the reason. So we published our result in archives, disease children, fetal neonate. So please find it. And also, Professor Julie introduced this textbook. Last year, we published this textbook from Japan. Today's my talk is included in this textbook. Please find and get on website. Thank you so much. This picture is last November on World Premature Day. So old Matsumoto Castle is light up purple. Thank you very much.
Thank you, Professor Nakamura. May I ask if you could go back to your ventilator settings, the slide for NAVA. I think I have a lot of questions anyway to ask you. I'm not sure what the audience has. So if you could raise your hands or type your questions on the chat group. Yes, that setting there. If you could show the slides, may I ask when you would decide to change the baby to invasive NAVA?
It's very difficult question, depending on the babies, because spontaneous breathing is very important on NAVA. If the spontaneous breathing is very weak, it's not fair, it's not success. So try and error. First, we change to NAVA, and we change to the backup rate, and sometimes we failed to back to the synchronous IMV.
So if you have a 22-week infant that's more than 500 grams, would you start the baby on NAVA or would you try SIMV first?
First, we tried SIMV first.
Okay.
Maybe the 22 is a very difficult to use NAVA because you know
Okay.
the alternate dressing is very weak.
Right. Okay. If anyone has, are there any questions of Professor Nakamura on the NAVA settings that he has put up on the screen here? No. The other question I had was in your acute phase settings, a few slides before, you targeted quite low CO2s, 35 to 45. Yes. Is that something that you aim for as a routine in your practice, even for the 22 to 23 week infants? Because we are taught to have a higher threshold for CO2s.
Yes, very nice question. Because at that acute phase, especially 22 and 23 gestational age patients, it is very difficult to pH because sometimes they have the metabolic acidosis. So we have to use the some kind of the medicine. So we use this little bit low PaCO2 in acute phase.
Okay,
However, we change to the respiratory setting to much more low PA or PIP, try to this PaCO2 level.
Thank you. We have a question from Luke Jardine from Brisbane. Luke, if you want to unmask yourself and ask the question, because I'm not sure what you are asking.
Yeah, thanks, Julie. It was more just a question about the VN 500 and the initial hertz setting in your older strategy for using HFOV. I was just wondering why you chose 12 hertz over perhaps a higher frequency.
You mean like 13 or 15?
Correct.
Yes, it's a very difficult question because I think frequency is a very difficult, more suitable frequency for premature babies are known. We don't know. Maybe it's a much more higher than 12, 13 to 15. Is it that my answer is correct to your question?
I think what Luke is suggesting is that maybe a frequency of 12 is, frequency of 12 is able to provide more tidal volume than 13 or 15.
Yes.
I think in Australia, many of us will start from 13 for a very tiny baby. Is that your experience, that you do not get the amplitude with that, with levels higher than 12? So that frequency of 12 would be your standard setting for a 22-weeker.
Yes, thank you very much. Your suggestion is good. Maybe we will try.
Yes, so.
Yeah, Julie, we find with the VN 500, we tend to start with 15 hertz and an IT ratio of 1 to 2. And we always use volume guarantee, but we often find the amplitude maxes out with the VN 500 somewhere around the 15 to 20 centimetre mark. And the only way to really overcome that is by dropping the IT ratio back to 1 to 1 or decreasing our hertz.
Thank you very much. Nice. Thank you very much for your suggestion.
Okay. It is probably an art with very little evidence behind a lot of these settings, but I guess what really needs to work is that your team's comfortable with it. Dr. Yuan has asked, when you're switching to NAVA on day of life 3, do you still keep the low dose of fentanyl? And I guess the question is, how long do you keep a baby on fentanyl for?
3 days.
Only 3 days.
Only 3 days.
Oh, okay. Okay. Thank you so much. All right. The fellows from Royal Women's Hospital in Melbourne would like to ask about the dose and the frequency of the fluticasone therapy. When do you start? How much do you use? And how often do you use?
We start in 1 week, hopefully during 5 or 6 days to 3 weeks. So long, 21 days. So dose is I'm not sure. Only the one puff of the fluticasone twice a day. So I'm not sure, but if you like to know exactly those, so please find my article.
Yes. Yes.
I
think
I forgot that. Exactly.
No worries. Yeah. Sometimes people use 50, 25. Does it depend on the weight of the baby, or is it a standard dose?
Yeah, that's a good question, because we don't the standard dose of the very small babies, because inhaled steroid is directly to the lung, so we don't know the exactly reach to the peripheral lung. So we roughly use the puff, just only one puff, to not intravenous corticoid. So it's roughly those we used.
Okay, so what you're saying, Professor Nakamura, is that every baby on day 7 will receive fluticasone at a standard dose twice a day for 21 days.
Yes.
Okay. Thank you. And the fellows say, would you use any systemic steroids as well?
Not routinely, just rescue. Just rescue who had the very severe respiratory setting for severe VPD. We just use the rescue therapy to decrease the respiratory setting, or oxygen to decrease the oxygen. Only the rescue therapy, systemic steroid.
Okay, thank you. And there's a question from Dr. Janice. I'm not sure whether I've said your name right. How do you gate the NAVA? Via NG tube with sensors? If so, isn't positioning very difficult? Dr. Janice, I'm not sure what gating means. Maybe you can unmask yourself and ask the question.
Yeah, you're right. It's very difficult to setting the position of this tube, especially very small baby. And also if the change the position, the little bit change to this tube position. So sometimes we cannot get the correct data. So still now we are trying to small baby in NAVA.
What is the smallest baby?
Yes, it's a very important to this EDI catheter is a very important to the position.
What is the smallest baby you would use the NAVA ventilator on?
Usually over 500 grams.
Okay.
Yes.
Okay. Right. Okay. Jim is
It just seems
asking
that
with not. Sorry. Yeah. Hi.
it just seems that even sort of in term babies, it's actually quite difficult to get the positioning right. And as soon as you're a millimeter out, it doesn't really quite synchronize with the ventilator anymore. And then you push it in, and it seems to be a permanent in, out, and are all the sensors measuring or are they not measuring? Thank you.
Thank you. Yes, you're right.
So where do you come from? Sorry, Dr. Jen, is it Janice? Sorry.
No, we're a group here. We're in Hobart.
Oh, right. Okay. So you don't use NAVA routinely on your little babies, right?
Yeah, I come more from a PICU background, but we have used NAVA routinely in PICU, and we found that even with the newborn babies that we use it on, it's just extraordinarily challenging, and to the point where we've almost given up on NAVA just because it is so hard to get the gating, whatever you want to call this, right. So it actually transmits the signal into a respiratory signal. Can be just fiddling and fiddling and fiddling.
Just absolutely. Yeah, totally understand. I think you really need to be very comfortable with NAVA. Jim asks, with NAVA, is there a PIP that would require you to change to HFOV? I think you have a slide there to show that some babies are placed on HFOV for a certain time. When would you change the baby from a NAVA setting to HFOV?
So until 2020, so we use the first choice is HFO after the first use of the SIMV. So when we think this baby will be extubated soon, at that time we changed to the HFO from HFO to the NAVA to stimulate the breathing, spontaneous breathing to extubate. So this is also all our strategy. So because during the HFO, spontaneous breathing is very weak. You know, sometimes the diaphragm weakness has happened on baby. So we just training on spontaneous breathing on NAVA. So at that time, so we think about this. This is a story from the HFO to NAVA. Is that okay?
But the other way round. So if the baby goes on to NAVA first, when would you change the baby to HFOV?
Your question is from NAVA to HFO.
Yes.
Yes. Now we are just rescue therapy. HFO, we use the HFO for rescue therapy because some patients with severe BPD, they cannot ventilate on NAVA or SIMV. So we changed the HFO for rescue therapy.
Does that answer your question, Jim? No answer. Okay, I might go to Jackie and then go back to Brad because Jackie is from Liverpool Hospital in Sydney, where they are increasingly using NAVA, invasive NAVA and non-invasive NAVA. So Jackie, would you like to tell us about your experience with the nursing staff looking after the very tiny babies with the NAVA tubes?
Yes, I just made a comment there in the chat. Thanks for coming to me, Julie. I wasn't expecting that.
I know, right? You got to do your hair.
Yeah. Look, I think, we use NIV-NAVA a lot. We use non-invasive ventilation a lot. And you're right, it is difficult to get those tubes in the right position, but I think it's very much a nursing staff skill, and it does take time. But you can do it. I mean, we don't have a lot of experience with kids under 500 grams on NAVA, to be fair, but certainly 500 grams and over. I mean, if you're having trouble getting your NAVA tubes to stay in the right place, I think it's a matter of working with your nursing staff and getting that skill level up. Yeah.
Thanks, Jackie. I mean, like, how do the nurses get trained up to make sure that the NAVA tubes are in the right position?
I think that's a hard question to answer. I think if you're a unit that uses NAVA all the time, then that's what you train in. It's not, many of our nurses now haven't used other forms of ventilation. This is what they do.
Right.
So it's what they learn as their, you know, it's their go-to. They've learned it right from the start. It's second nature, I guess. And once something becomes a good habit, it becomes reproducible. So I suspect that the answer is it takes time and training. But if you're training a whole pile of nurses for whom this is the only thing they know, or the main form of ventilation that they know, then you just get used to it. Yeah.
Right. So NAVA is your predominant ventilator mode now.
It is, and they don't move very small babies. I mean, you move them, they do, but if you've got them well nested, they're not thrashing around the bed. So maybe that's part of it as well.
Okay. Thank you. Thanks, Jackie. We might go on to Brett, because Brett's asking about systemic steroids, Professor Nakamura. The 22-weekers, he's saying, Brett, you can ask your questions. It's a long one. It's almost severe evolving BPD. Would they all get systemic steroids?
Yeah, I'm not sure the percent of
Thanks, Prof. Nakamura.
Yes.
Yeah, Brett. Yeah.
Sorry, my internet's very dodgy. I think Professor Nakamura was answering the question. Please do.
Yeah, please go ahead.
I was wondering, Professor, do all the 22 babies get systemic steroids?
Yeah, I'm not sure the exactly percent of the systemic steroid on the 22 gestal age. Perhaps most of patients in 22 need systemic steroid. I'm not sure, but the most part of the patient need systemic steroid.
But in your practice, every 22-weeker would get fluticasone.
Yes.
Okay. And systemic steroids will be used as a rescue?
Yes, just rescue. So just we decided they need systemic steroid for some reason. So respiratory or circulatory collapse or something. So at that time we used, not routinely.
Okay. Maybe, Brett, we could ask Rose, what is your Victorian rates of steroids for the 22-weekers? Rose Boland?
Really putting me on the spot.
I am.
If you can come back to me in about 2 minutes, I can tell you, because I'm literally looking at these babies at the minute on my second computer in Stata. Ask someone else a question and I'll come back. This is you only want the babies who get active care though, right?
Of course, the ones that actually make it into your NICU and is provided with active intervention. Yes.
Yeah. Give me a sec to run it and I can tell you.
Hot off the press news. Brett, you would be saying that most of them would get systemic steroids, right? I think in New South Wales, we do not have a 22-weeker that has survived to hospital discharge. So Jackie, you have experience of 22-week infants in Liverpool.
Hi, Julie. Just give me a chance to do my hair again and stop eating.
No, it looks beautiful.
Oh, thank you very much. Look, we're certainly willing to manage babies at 22 weeks, but it's kind of like one of those things, you write a protocol for something and it goes away. So I think last year we ended up managing about 3 and lost them all. And we haven't had a 22 weeker since we've moved into our new unit, which was beginning of December last year. So we've certainly had women present at 22 weeks where there's been an arrangement that yes, we would resuscitate, but none of them have actually delivered at 22 weeks. The pregnancies have all progressed. So yes, we are willing, and yes, we have tried, but it's certainly not a regular thing because we're just not seeing them.
And did you use dexamethasone in all of them?
Julie, they all died relatively quick.
So, yeah, okay.
So not at a point where where chronic lung disease had reached a point where we would be thinking about rescue Dex, yeah.
Yeah, okay, so no. Right, and Brett said that systemic postnatal steroids would be given to babies at high risk of BPD, and the risk at 22 weeks must be close to 100% when they remain on mandatory ventilation, so I suspect most of them would get steroids. So maybe Rose has the data from Victoria?
Oh, Julie, you're putting me under pressure here.
I know your computer has to work faster. It's not so slack.
So I was on a different train of thought because I was looking at antenatal corticosteroids, so I don't have the complete data for postnatal. I can tell you we had 18 22-weekers offered active care in 2023, and we had 3 survivors. But still small numbers.
Very small, yes. So Professor Nakamura, we do not have the experience that you have. Luke is also saying that they frequently use hydrocortisone early for hypotension and then dexamethasone later for BPD. That is your experience as well.
Yes,
right?
yes,
You're nodding.
Yes.
Okay, and can I ask about your non-invasive mode of care? Are you still extubating? Sorry, the previous slide where you showed that the babies were extubated about 32 weeks. Yes, this one. Would you be extubating now as a routine to NIF-NAVA? Or would you do something else like bubble CPAP or ventilator CPAP?
Yes, we use CPAP system. However, now NAS likes the NIV-NAVA much more than CPAP system because infant looks much more comfortable on NIV-NAVA compared to the CPAP system because on CPAP, infants has a stomach.
Yeah.
Stomach is so maybe the NIV-NAVA is much more comfortable for infants, small infants.
Do you still keep them intubated until 32 weeks gestation?
Yes. Not so. We not to try to extubate as early as possible because on NAVA, the patient looks very comfortable. And also the body weight gain is very good on NAVA. So now we are a little bit changed to try to extubate as possible is not so comfortable for the infants. So we are still, extubation time is around the 32 gestational week. At that time, so far now, not so changed.
Okay, so the same.
Same.
Okay, so if you have a 22-weeker or a 23-weeker, they would spend 10 weeks on invasive ventilation.
Yes.
Okay. And Rose, do you have data on your amount of invasive ventilation for your little babies?
No. So the data sets I'm using are our perinatal statewide data for the births. So in order to get information on what happens in NICU, that has to come from either the ANZNN data or the people's personal NICU database. Essentially, you can see Louise Owen from the Women's is talking about how many babies they've got there. So we would have to draw that from each individual unit. I mean, the good thing is in Victoria, there's only 3 units really caring for these babies, so that makes it easier to pull that data. And certainly, I think Jen's online, Jen Walsh, I think, is there. Those interested in collaborating with the Tiny Baby Collaborative as well to start reporting the experiences and what people are doing in terms of ventilation, fluids, feeding care, etc. Interesting, Victoria really use NAVA much in Victoria compared with, say, New South Wales, so it's quite a different, ventilation strategies. Brett might like to comment on that.
Yeah, Brett, his internet is dodgy. No, Brett. So maybe you can ask Luke if your tiny baby unit in tiny baby NICU in the Mater, would you actively keep 22 weekers intubated for a protracted amount of time?
Yeah, thanks, Julie. Yeah, we've definitely changed our strategy. We tended to be early extubation for any baby who was ventilated, but we've the 22-weeker and 23-week babies we've recently intubated for resuscitation. They have stayed ventilated for a prolonged period, so probably 4 to 6 weeks at the minimum.
Right. Okay. So you are going down the Japanese path now.
Yeah, we're trying to mimic some of their success, but we're still a long way off, that's for sure.
So Brett, your internet is in the cluster. There were 150 22 to 23 week infants, and first average extubation age was 2 weeks, so 70% extubation failure. Wow. And why do you think there's a high extubation failure, Brett, especially when other countries like Sweden, have a high rate of non-invasive ventilation in the early days? He can't talk. Yeah. Extubate too early. Okay. So I think the strategy is pointing at prolonged ventilation for stability, isn't it? I don't know. And Louise, you're saying I can't, not really sure of your question actually.
Not a question, Julie. Just making a comment saying we with these super tinies, we've sort of modified our thinking from early extubation at all costs really to a bit more stability. I think the reason for non-successful extubation is multifactorial, many things.
Yes.
So I think we're sort of moving in the 22 and 23 weekers to giving them a bit more time to grow, for the skin to mature, to develop the respiratory drive.
Okay, so the same as what Luke's saying, stability for about a month and a half.
I don't know that we've quite got to that long. I don't think we have a policy. We're a couple of handfuls of babies in, but I think we're not trying to get them extubated in the first 36 hours like we might do with an intubated 24, 25 weeker.
Okay, right. So it's the different species, isn't it? 22 to 23 weeks.
So.
But whether we should even consider going as long as Professor Nakamura is saying to 31 plus 6, maybe a question to look at. I'm not sure. So, Professor Nakamura, would the prolonged intubation be a typical practice in all units in Japan, or just your unit?
maybe only 1 hour unit, because most of the NICU in Japan now still try to extubate as early as possible. Just as the world strategy, yes.
And
however, the 22 and 23 gestational week infants in Japan, not so many NICU has experience in very, very tiny baby. Only the small NICU, only maybe the under 10 NICU has the experience. Maybe they feel the infants, very premature infants need much more long time ventilation period, not such as over the 24 and the 26 gestational week premature infants.
Right. So what you're saying is that the care of the very tiny babies in Japan are limited to about 10 NICUs.
Yes.
Oh, only. Okay, got you. And most of them would have prolonged intubation.
Yes.
Okay, right. That's certainly some food for thought. Dr. Chauhan has a question. What strategies do you use to prevent these tubes from being colonized and getting ventilator-acquired pneumonia and lung injury? Because that would be a major concern with having a tube in place for such a long time, infection.
Yeah, that's a good question.
Do you have any advice for us for preventing infection while the baby is intubated for a long time?
So I'm not sure, because what is the difference between our NICU from the, I'm not sure, but we use a closed circuit aspiration system. So do you use closed circuit aspiration circuit?
Yes, we do.
It's closed, it's the same.
I think
we don't do the special.
I think, Dr. Shoban, their nursing care is incredible in Japan. They have a very, very high, not high nursing ratio, sorry. They have a very regimented nursing staff that are very conscientious of their nursing care. And they have a lot of children who are ventilated for a very long time, but VA ventilator-acquired pneumonia is a quite not as common as elsewhere. So I think the nursing care is the key to this prevention of infection.
Yes,
that's right.
Right.
And like
yes.
Luke says, regular ET surveillance, very frequent CRPs, and very, very prompt and early treatment with antibiotics.
Yeah, nursing care, Japanese nursing care is very special. They have the very traditional skill, and sometimes I say, not science. They do the art. They are just artists.
Artists, exactly.
Artists.
So medicine and nursing is an art. Yes. Yeah. So for those of you who are interested, in October we have a conference in Saitama, an Hippocrates conference, and there might be an opportunity for Dr. Fumi Namba, who's a professor of research there in neonatology there, to organize some visits to the Saitama unit, which is currently, I believe, the largest unit in Japan. So I will send the details on the WhatsApp and email groups afterwards, including with the recording of this talk. So in the meantime, I guess, Professor Nakamura, we're coming up to the hour. If there are any more questions, if there are no more questions, perhaps we can close the talk now. Would you, if it's possible, I could post this talk on our website and for people to contact you if there are any further questions?
Yes.
Thank you. Thank you so much for your time. And thank you everyone for the great and very interactive discussion. Hopefully we'll see you in Hippocrates in October for more chats on how to look after the very tiny baby. Thank you so much.
Thank you so much.
Bye-bye, everyone.
Thank you. Bye-bye.
Bye.
Mm.